Hey everybody, I wanted to give a brief talk on how to properly ask for code status. This is really intended for healthcare workers such as physicians, but it also could apply for nursing staff that sometimes get involved in these discussions with family members about loved ones' wishes with respect to end-of-life choices. To start with, just to clarify, a do not resuscitate order really only changes the care of the patient in the event of a cardiac or respiratory arrest. The presence or absence of a DNR order should not determine treatment short of CPR. You can do withdrawal orders if you decide to withdraw support or forego life-saving surgery or dialysis or some other issue, but technically speaking and legally speaking, if it's a do not resuscitate order, this should not affect care up until the event of the emergency or cardiac arrest, respiratory arrest, and so on. Family members and healthcare workers need to understand this, as it's easy for people sometimes to question treatment decisions and say, oh, the patient's just a DNR, we shouldn't treat their pneumonia, we shouldn't treat their infection, we shouldn't give them IV fluids, we shouldn't give them artificial food, we shouldn't do that surgery, blah, 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 because they're a DNR, and that's really inappropriate use of DNR status. Other end-of-life decisions, such as might be covered by a living will, can address some of those issues, but for DNR purposes, it needs to really come down to whether resuscitation should be used or not. Many times this decision is made on the basis of futility. If it is futile to do CPR because the patient's going to die in spite of the CPR, physicians really aren't required to give it, though sometimes can be pressured into it just to avoid the risk of legal action or problems with hospital administration, which will not always support the physician's decision, but that's just another factor to consider in this. In the United States and probably in most places, we agree that a patient who is competent should have the right to determine what happens to them with respect to medical treatment. We require informed consent for a variety of procedures, and this is how it should be, that the patient should be informed and should give their consent or fail to give their consent for treatments that they don't want, and this can include CPR. So these discussions are best held when the patient is able to participate in the decision because they have the final say. And patients are allowed to have poor judgment if they are otherwise mentally competent. You may not always agree with what the patient says, but unless you think the patient is mentally ill, you have to abide by the patient's wishes with any reasonable medical request, and this would include being do not resuscitate. A reasonable medical request might not include situations where the patient demands an unproven treatment or something that is contrary to standard medical practice that the physician has to agree to or not agree to. But in general, a patient should be able to withhold consent from things like CPR. The problem frequently arises where there's no pre-existing relationship with the patient, particularly for the critical care doctor or the emergency room physician who sees the patient in a time of extremis. Maybe the patient has already been intubated or has altered mental status and is unable to participate in the conversation. In this case, you have to talk to proxies. Ideally should be the legal next of kin or someone who has a healthcare power of attorney. The mistake in asking for a do not resuscitate status is you come up to the family member and says, well, if he has a cardiac arrest, what do you want us to do? That's like the worst possible question. Because if you brought your car to a mechanic and he says, your car has a broken Verschlangener valve, what do you want us to do? What kind of question is that? You're paying the mechanic to give good advice and tell you what the best course of action, or to at least present you options with the pros and cons of each course of therapy for your car, and the same should be true with patients. If you ask the question like that, you're almost always going to get the answer, do everything you can to save my loved one. And that's not always the appropriate answer. That's the easy way out, and physicians that use that kind of approach to get DNR status are going to later be complaining, oh, they didn't know what they were doing. They made a terrible decision. Why didn't they decide the correct way? Well, you didn't give them any guidance. How do you expect people that are not medically trained to know what the right thing is? And many times if you ask a question like that, it almost turns into a love test that of course we want everything done to save grandpa. And that's not always the right thing to be done. And patients, family members often worry that they'll be second guessed by other relatives, especially the relative that maybe has been ignoring the family member until the last second. They're 1,000 miles away, can't be bothered to be concerned with the patient's daily life or their decisions for healthcare, and they come in at the last minute and try to criticize you, the one that actually lives with the person or is their primary caregiver or has their healthcare power of attorney, making these decisions as if it is your decision. One thing I always make clear with family members is this is not the decision of the family member. I'm not asking for the family member's decision because, again, the patient has a right to self-determination. And who better than that close family member to tell us what the patient's decision would be under the circumstances? I find it very important and very useful to make sure the family member know this is not your choice, this is not what you want, this is what you know the patient would want if they were able to participate in this conversation and they were informed as well as you have been informed by me about the pros and cons of doing resuscitation. Under this circumstance, you can relieve that patient of the guilt. You're allowed to give your opinion as to what the best course is or what you think most people would want under the circumstances, knowing all the facts and circumstances of the individual case. And in this case, family members, they may want their grandpa to live forever, which is not unreasonable, but at the same time, they will be more willing to make the difficult decision of doing what they darn well know grandpa would want under the circumstances. And they know that grandpa might not want to be maintained on an artificial life support if there is no hope of recovery, even though they might like to hold on to that 1% chance of recovery. So never ask the patient, what do you want to do? Or never ask the family members what you want to do. Give your best advice. Tell the pros and cons, what you expect in terms of their likelihood of survival with or without CPR or with or without intubation, and make it clear to any proxy caregiver that the decision you're looking for is the decision of the patient. And if the patient can't speak, you need those people that know the patient best to speak on that patient's behalf. Many patients have told family members explicitly what they would want, and that makes it nice and easy. Many times the choice has never come up, but yet the patient's families know the patient family member and can predict with pretty good accuracy, I think, what would be the best thing under the circumstance. That's the basics of how to do this. Always make this about the patient's wishes, and the family members or power of attorney, etc. Their job is to speak on the patient's behalf and represent the patient's best interests and not the interests of the soon-to-be grieving family members if that's the direction they choose to go. If you have any comments or other suggestions about this conversation, feel free to leave them in the comments below. I may do another video aimed at family members who are dealing with this situation to better clarify the roles of DNR orders and how this affects care. But let's see how this goes. Until next time, see you later.